it's helpful to kind of hear all the different perspectives from people, their journeys, their frustrations, their goals.
No offense to the clinicians, but we impact more people. Our reach is wider. We get to, further the future of medicine.
And so I think that's where my mentality went. I was like, how can I have the biggest effect on the most people?
Hi everyone, my name is Irene and welcome to Purpose, Why Medicine, where I speak to professionals in healthcare who exemplify living with purpose and want to share their unique journeys, experiences, and learnings with our audience. I'm here today with Dr. Scott Herskovitz, pediatric emergency medicine physician, clinical director of emergency medicine at Rady Children's Hospital, San Diego, and associate clinical professor for the Department of Pediatrics at UCSD Health, as well as Dr. Marnie Jacobs, assistant professor in the Department of OBGYN and Reproductive Sciences at UCSD, and steering committee member of the Center of OBGYN Research and Innovation. Thank you both for being here today.
Thank you. Thank you for having us.
Before we get into your individual careers, did either of you always know you wanted to go into medicine or research, or did that interest develop later?
Oh, I'm going to start?
Yeah, go for it.
No, I did not always know I was going to go into medicine. I actually thought I was going to be a lawyer for a very long time and didn't develop an interest in medicine until I was in college. I really liked science growing up and really liked math, but wasn't quite sure that I wanted a career in it, and until college I didn't know which way I wanted to go.
I don't even think I knew that. That's interesting. I didn't know you wanted to be a lawyer. Yeah, I think for me it was always, you have those childhood dreams that are ridiculous. Like, I wanted to be an NBA basketball player, and very quickly realized that was not going to happen. So from there, I think my mom was a nurse. She was a nurse at Children's Hospital, Los Angeles. And so she worked in the PICU there, so the pediatric intensive care unit. She worked on hematology oncology. And so from there, I think I saw what she did, and I think it was always something that I think from a younger age that I wanted to go into medicine and be a doctor. I think that the type of doctor has changed over time. At first, it's just, I want to be a doctor. I don't know what that means, and we'll figure out how we get there. But I think my inspiration really was kind of my mother and trying to sort through how to make that happen.
Very nice. I'm interested about, do you think there's any overlap between your interest as being a lawyer and your research now, or in medicine?
I don't think so. I shouldn't say that. I think what drew me to being a lawyer, maybe this my perception of what a lawyer was going to be, was kind of making arguments and, trying to convince people that, how you see a situation is correct and getting people on your side. And research is kind of like that, but on the science side, you're trying to convince people that what you're finding in your research is right and has value. So maybe that's some overlap in it, just in a very different situation.
Mm-hmm. Definitely. So let's dive deeper into your journey to medicine, Dr. Herskovitz.
Sure.
On paper, you've had quite an interesting educational journey, having attended UCSD as an undergrad, flying to Sydney, Australia for medical school, then returning to the States for residency in Louisiana. What led you to Australia for medical school?
So it was kind of an interesting pathway. I think UCSD was a lot of things were kind of unexpected journeys. I think that's where it kind of went for me, and I think there was always an idea of like where you went. I think everybody going to college, you have this idea of like, I want to go here. I want to be at this institution, that institution. And so I think being in California was great. UCSD kind of was an opportunity that it wasn't my first choice to be at. But coming here, I think I was put into a good environment, I think, with really kind of good friends that I met that kind of built a nice structure for support. And then from there, I think you go from when you're a high achiever in high school and things are easy. I think things were so simple. I didn't have to put in any work in high school. And then in college, I kind of kept that same mentality, and it didn't work very well. And I think from there, I had done something called a people-to-people student ambassador program when I was a little bit younger. And we went to Australia and kind of like traveled around, lived with families, and I always wanted to go back. So I actually didn't apply to any U.S. universities, and I just applied to Australia. So some of that part was because I had so many friends who studied abroad in college, and I didn't have that opportunity going into medicine. It was very kind of difficult to take a semester or something like that and go overseas. And everybody kind of had a good time. It's a little bit different in undergrad than it is in graduate school. So, yeah, I applied to University of Sydney. I was accepted, and I had no real reason to stay. I think that my family's in Los Angeles, and there was an impetus to kind of get a new experience. And I really wanted to kind of get pushed outside of my comfort zone. So that's how I went to Australia. That being said, funny enough, I met, obviously now wife, right before I left. So that was an interesting occurrence to kind of deal with and sort through, and trying to do long distance for that time. So I could go much longer into how all this went, but essentially it was Sydney, Louisiana, DC, and then back to San Diego. So for me, it was very much different experiences, being outside of your comfort zone, being kind of pushed to try and excel in those areas, and then also trying to see what opportunities arise, and not necessarily being so concrete and I'm going to do A to B to C. It was more of what opportunities are there, what is opening up and that I can do.
Well, you definitely had a reason to come back to the States.
True. That is true.
A very good reason. I'm curious about how, I guess, licensing works if you do medical school in Australia versus in the U.S., because I know that there's some questions about, like, if you go to the school in the Caribbean and how that works. So how does it work for Australia?
Yeah, so this was something that I didn't really look into beforehand. And so I think it was more of an idea of a change and something different. When I was there, you don't really think about it either in the beginning. So not really in those first 2 years when you're very much kind of in the classroom. You have some clinical time. But then when you start to think about that year 3, year 4, and you have to sort through some of your clinical rotations back in the U.S., and trying to look at what does it mean to come back to the United States, it wasn't always my goal. I thought about staying, and most of the people who actually went to University of Sydney stayed. There were only a couple Americans in my class. There was a bunch of Canadians as far as that were international, but most people wanted to stay. And it was certainly something that I had thought about and wouldn't have minded living abroad. So, however, there was some kind of political changes that happened there that they kind of took priority over the training spots for the Australian students. And so from there, it kind of changed a little bit of my mentality regarding coming back. That being said, she was still here. My family, obviously, in LA. My mom has some medical issues, so it was kind of like, it's really far. And so I just looked at what you had to do. And essentially, you just have to do the same thing that the American students do. You have to pass the USMLEs. And I think the difference, though, was if you go to the Caribbean, they train you to basically like pass those tests or do well. In Australia, at the University of Sydney, they're training you to be a doctor in Sydney, in Australia. And so they're not training you to do well on that test. Medicine is medicine. It doesn't matter where you're at. However, there is something to be said about training or studying for a test. And it was very much an individual occurrence or kind of endeavor to do versus whether you're in the U.S. or in the Caribbean, being like, you need to pass these. And I think the other thing that was significant was trying to figure out how to do clinical rotations back in the United States to get letters of recommendation, because it's quite big. and people don't know you. And even though University of Sydney is a fantastic school, you still, if you're at Boston, if you're at UCLA, if you're at Davis, they know what American universities, med schools are. They know the type of students that are coming out of there. They don't really have the biggest idea of what University of Sydney is. You know, I think that's something that you have to try and overcome. And there were some of those things, but to be honest, it was always a good story with some of the interviews and doing clinical rotations. So, yeah.
Yeah, I mean, it's definitely something that will make you stand out.
It certainly did. There's a lot of like, do you have an Australian accent?
Yeah.
She would say when I would come back, she'd be like, you've picked up a little bit of an accent. So it was maybe
one of the
not
perks.
too much, I guess. Yeah.
Great. So why did you choose to specialize in pediatric emergency medicine?
So I initially actually wanted to do orthopedic surgery. That kind of led from my love of sports. Moving into orthopedics was something that I wanted to do with, again, some of these very lofty ideas of being, the team doctor for the Lakers or something like that, growing up a Lakers fan. But it's very difficult to get in to do something like that. And it's not something that you can necessarily bank on. So I think for me, I did a bunch of orthopedic rotations. I did more in Sydney. I actually came back and did an orthopedic trauma rotation at UCSD, which was fantastic. One of the best rotations I had. That being said, I think she was here. She was doing her PhD at the time, and she was like, "You're never around," because as a med student doing that rotation, it was like 120, 140 hours a week at the hospital, and it was rough. It was fun, but rough. So I think I enjoyed it. I think there was a realization, though, that I didn't want to be as much of a specialist and be more of a generalist and be able to do some of the orthopedic work. So emergency medicine kind of came to the forefront, and that was an area where I feel like I could do a lot of different things. I could do orthopedics, I could do ENT, I could do pediatrics. And so I did some rotations there and really enjoyed it, and it kind of changed my perception on what I wanted to do, what was feasible, and then at the same time, people don't think about this as much, and I hope that they do going into medicine, is you really do have to think about lifestyle. And people think that talking about finances is dirty in medicine. But that being said, you do have to think about the financial implications of what you're going to do, because going into medicine is a significant cost. And it's also a significant sunk cost that you are also then not having any revenue for quite a few years or minimal, while your friends, who maybe they start off making some money, are now building all that equity over time that you've lost minimum 10 years. So emergency medicine kind of provides a different kind of venue than some others. Yes, you're not, as an orthopedic surgeon, you're making quite a bit more. But lifestyle-wise, it's a solid lifestyle. So I think that was some of the turning points.
What about the pediatric aspect?
So that's where I kind of go back to my mom's influence. So her being a pediatric nurse really was one of those things where I never thought I would 100% do pediatrics. I liked it. Kids are fun. They're resilient. You actually get to fix things. And, parents want the best for their children. They want to make sure that their kids are going to be all right. And so I think when I did some rotations in pediatrics and pediatric emergency medicine in particular, it was a very different space to be in. Adults is a lot of lifestyle issues. And so are you really fixing something? I don't know. And to be honest, we need people doing that. But in pediatrics, I think you get the benefit of, you're basically an educator. 90% of the time, people are coming in because they're concerned about their children. Something horrible is wrong. It's probably one of the worst days of their lives coming into a pediatric emergency department. But you get the opportunity to educate them. It's kind of a responsibility and a place where you get to be there for a family and for a patient, and you really have to make a connection very quickly, gain their trust very quickly, because this is their child, and it's fun. And the kids, even when they're sick, they're still, you can make them laugh. They respond obviously much quicker than adults do, and for the most part, they're going to be okay.
Yeah, they're very resilient.
They are, yeah. Yeah.
Well, I want to bring it back to the both of you. You mentioned about how you two met before you had to leave for medical school, but how did that happen?
We actually met at work. So I had moved out I'm originally from the East Coast. I had moved out to California to do a PhD, but had taken a gap year. And so I couldn't move out here without working. And so I worked for a CRO, which is like a clinical research organization that helps do research for mostly big drug companies. And when I started working there, he was working there in between undergrad and medical school. So yeah, we met at work. I think we only overlapped for a few months, though.
Yeah, it was a solid 2 months, 3 months maybe. Yeah, it was not long.
No, so we kind of met, and then I just moved to San Diego. It's like, I'm not really looking for anything serious. And he's like, that's fine. I'm leaving for medical school in a couple months. And I was like, oh, this will be perfect. You've been living in San Diego. You can show me around, and then you can go to medical school, and we'll move on with our lives. And that didn't happen. He stuck around. So, yeah.
That's fair.
I guess, what were the unique challenges of having to navigate that distance, and any tips for that?
Well, the funny part is, this is going to say date us a little bit, how old we are. This was before smartphones. So that was a really big challenge, was when he left for Australia, I was like, I don't know how we're going to communicate with each other. It was very kind of a black box of things. And I think you were calling for payphones for a little while. And then we were setting up, because of the time difference, we would Skype all the time. And so, but I had to be at a computer. So I'd be waking up to go to work, and you would be going to bed.
Yeah.
Usually. So we would do Skype dates every day. And then, like I said, we didn't know each other that long, but then he was like, why don't you come out to Australia and visit? I was like, are you sure? I was like, yeah, come out. So he went out about 6 months later, and then we tried to see each other every 3 months or so. So one of us would be flying, either I would be going to Australia or he would be coming back to San Diego.
Yeah.
Yeah,
I think it was challenging. I think, again, with the invention of the iPhone, and having that was very, very nice to have, except for we didn't have it, right?
That
so I think,
huge.
I think I had, I remember I had this weirder Sony Ericsson that had Skype on it, a Skype enabled phone. And I was like, oh man, this will work. So it honestly, the technology part of things was helpful.
Yeah.
I think the other part of making sure that we set up time to talk to each other. I think this was weird. I sent emails every single day, just kind of what was going on, and then trying to have that time when she would come out or when I would go back. Obviously during my breaks I could go back, but the benefit of it was in Australia the school system was flipped. So my breaks were over winter, and that was their summer, and obviously her breaks were during summer here. So she could come out for longer periods of time. And I think over time we also were able to sort it out where it was beneficial not only on a personal side, but also from a educational professional side, is we were able to arrange for her to come out during her summers and do research at University of Sydney. And so we were able to kind of set that up. And I think it was beneficial where she got publications out of it. She made contacts. It's for the research that she does, it's still a relatively small world. And so, you still hear from people or see people at some of the international meetings. And I think it ended up being more beneficial than maybe we originally thought. Like there was certainly it wasn't doing nothing for you when you came out, which was kind of nice though, right?
Yeah, it was. And I also think, as weird as it sounds, it might have been a little beneficial that was all we knew, right? So this is how our relationship started. I can't imagine having gone from being with somebody a lot and then going into a long distance relationship, because that's such a huge change. But this was just our normal. And then we got to look forward to what might happen later.
Yeah.
So I think that was actually kind of helpful that that's how it started instead of falling into that later.
Yeah. Yeah. The travel was rough.
How many hours flight is that?
It's anywhere from 13 to 15 hours.
Okay. Yeah.
And yeah, so that was rough. I remember one of the times we had to, was it Thanksgiving or was it Christmas or something like that? Well, I flew back from Sydney to Boston because that's where her family is from. That was rough because I was very much oh man, I just got to LAX. This is great. I'm home, and then I was oh no, I got to sit another 6 hours to get to Boston, and so that was rough. But I think some of the travel, I wish we got to do a little bit more in Australia around the area, but it was hard. In medical school, you're busy. When she would come out, she would do work, or we would hang out, and also at the same time, it's not like we had endless amounts of money that we could go do, time and money to do things. So people were always did you go to New Zealand? Did you go up to Japan? And I was one, these things are not close. Japan is not close to Sydney. And New Zealand is relatively close. But, you're a medical student. You have to be really kind of, or for her doing her PhD, is you have to be conscious of the time you have and the money that you have, because everything that you do does start adding up on the cost of things.
Yeah, on top of the medical school tuition.
Oh yeah, oh yeah, definitely, which is painful.
I can imagine. So a few years ago, you served as interim division chief or medical director at Rady Children's Hospital. Mm-hmm. How did that come to be, and what was that experience like?
So my current role, I'm actually the clinical director of the emergency department right now, which essentially is the person who runs operations of the Rady Children's Hospital. And so we're one of the largest emergency departments in the country as far as pediatrics. We have over 100,000 patients that come through a year. There's, I think, only maybe 5 to 10 other children's hospitals in the country that have that type of volume. So it's really busy. Then before I was doing that, and this was kind of in the height of COVID, and our division chief or interim division chief at the time, he went on paternity leave. And so it was kind of a question of who's going to take over and do this for a couple months. And even though it was just for 3 months, it was also a really, really difficult period, I think, in medicine in general. I mean, we were dealing with staffing issues. You had some of the uncertainty around COVID. I think we had a little bit of a better idea about how things were going and some of the medical issues around it. But staffing was a massive problem, and our volumes were through the roof. And so I think with the work that I had already done as a clinical director, there was kind of this natural idea from hospital leadership and our division to be able to move into that. And I was the medical director at an emergency intake site, which was set up by Rady Children's Hospital at the San Diego Convention Center. So this was at the change of the administrations, and there was a huge kind of issue at the border with Mexico, with a lot of unaccompanied minors kind of being stuck and coming into the United States. And so the Children's Hospital set up this massive site that was kind of on the fly. And I had only been clinical director for, 3-4 months. And then they were like, hey, do you want to be the medical director there and kind of run the on-site operations of this? And I was like, yeah, sure, why not? I mean, I think dealing with underserved populations is like why you get into emergency medicine, because it's such a big part of it. And so it was a really kind of challenging opportunity to build things on the fly. And then I think because that was such a success, it led into, again, like opportunities open. And that led into, all right, well, why don't you take over as the interim chief, which has kind of dovetailed into a lot of other things. So I actually start in January as I'll be chief of staff elect at the Children's Hospital. And that is an opportunity that comes from your peers. So it's, I think, again, what kind of going back to some of the original things is some opportunities become available because of the work that you put in. And there's certainly some luck that's involved in hapstance, but I think I've put myself in a position through like the work that I've done as to be able to take on some of these other opportunities. And so that's where kind of clinical director, working at being the medical director at that emergency intake site, then being interim division chief, kind of temporarily, and then now in my current role it's been certainly a stepwise approach that has been, I think, pretty beneficial.
Well, congratulations.
Oh, thank you.
on
Thank
that.
you. Yeah.
2 years ago, you posted on LinkedIn a picture of you holding up a sign celebrating your first day of your MBA program, if you remember that.
Yeah.
And on the bottom right corner, you wrote that your goal was to become a hospital CEO. Why did you decide to get an MBA? And now that you've obtained it, is being a hospital CEO still your goal?
So the question of MBA was something that I kind of struggled with for quite a while. I think I've had a lot of good mentors throughout the way, which is crucial. And I think in some of the discussions I've had, it's like, well, I've done this Health Leadership Academy through UCSD. I've done this mini MBA, or I think this was called the Beam through UCSD. And it's like, well, what is the opportunity that's going to provide? What am I going to learn? It's an investment, right? Like, it doesn't come without cost, and whether that's financial or time. And so I think for me, I love clinical care. Patient care is still fantastic. It's very rewarding, even though the challenges on the day-to-day can be difficult. That being said, I think you kind of get into this idea of how much change can you actually affect on an individual basis versus if you get to a higher level, whether that's like hospital administration or other venues, are you able to affect more people? And so I think that's where my mentality went. I was like, how can I have the biggest effect on the most people? And how can I bring my work ethic, I think, how can I bring my vision, and how can I bring a younger person's ideas into an area where it's very hierarchical. Medicine is very hierarchical. And so that's where I kind of saw, I think, being CEO or something like a COO of a hospital really kind of was the pathway that I wanted to go, because I think, especially as a generalist, you see everything. You interact with everybody. And so I wanted to have that perspective that I could give to people in that role and be able to be kind of a facilitator and bring people together for the betterment of the physicians, for nurses, respiratory therapists, other ancillary staff. And because if everybody there is succeeding, then the patients succeed. So I think that's the way that I looked at it and still want to go in that pathway, versus I think the other way in the MBA is there's a lot of entrepreneurship, which is fantastic, or going in the going outside of the traditional clinical medicine or hospital-based medicine, again, I think it's a great opportunity to try and sort through that. But I don't know if that's my pathway. I won't close that door, but I don't know if that's my pathway.
Thank you so much for sharing your journey.
Yeah.
It's been very fun to hear about your various
All over the place.
experiences. Well, going to your journey to research, Dr. Jacobs, what first piqued your interest in researching maternal and infant health?
I actually fell into it. It was not an intentional journey there. When I was doing my master's at Columbia, so I was in New York City, I really wanted to be a real, general public health person that was going to be looking at. I was interested in emerging infectious diseases, so I wanted to be kind of like Dustin Hoffman in Outbreak and like investigating all these, zoonotic diseases. And one of the great things about Columbia is we had to do an internship, and one of the internship programs that they really tout is working for the New York City Department of Health. And so I applied to that program. I said I wanted to be in their infectious disease group, and they stuck me in maternal and infant health, and I was not thrilled. But I said, okay, this is an opportunity. I'm going to work for the health department, and I'm going to see what it's like, and then I'll move to a different division next time. And then I ended up really liking it. I found out that, you really are impacting, you get a 2-for-1. You're impacting both, pregnant person and baby at the same time, which was fascinating to me. And I said, maybe this is something that I am interested in instead of the infectious disease side, and kind of, never left.
But you did do infectious disease then in your PhD for some aspects.
I went back a little bit. Yes, I ended up doing some work in HIV. Just as part of my PhD program, I worked for an HIV prevention program. So I did sort of go back to infectious disease, and then obviously during COVID, every epidemiologist in the world probably ended up working on COVID. So I did go back to infectious disease a little bit, but my main focus is still maternal infant health.
Yeah.
So when I was doing research on your research, of course, I'm pre-med. I know a little bit about, the biological terms and stuff, but could you help break down your research interest for us everyday people? What is perinatal epidemiology?
Yeah, so epidemiology, kind of just as its most basic, is the study of diseases in populations, right? We're looking at how things manifest in people at a population level. And so perinatal epidemiology kind of takes that back just to the period surrounding pregnancy. So we're looking at things that either can affect having a healthy pregnancy, or things that affect conditions that arise during pregnancy. Our goal is really for anybody who is pregnant or wants to be pregnant to have a healthy pregnancy and deliver a healthy baby. So it's just, I hate referring to pregnancy as a disease. That's not what we mean. But, there are things that come up during pregnancy that can be not great for the pregnant person or for their fetus or infant. So we're trying to address those kind of complications that can arise during pregnancy.
How would you categorize your research or your day-to-day? Do you do like wet bench? Do you do clinical mainly?
Yeah, I do no wet bench research. I shouldn't say I do partner with people who do wet bench medicine or research, but mine is more in the clinical space. So I'm mostly working with patients who are volunteering to participate in research. I do mostly data analysis at this point, but it's really designing research to focus on conditions during pregnancy. And it's all clinical medicine, either from things that are collected routinely during clinic visits, or like questionnaires people are getting, samples or information that they're giving over willingly as part of research. And then I hand those samples over to somebody who's going to look at it on the lab side, and they just send me the numbers back.
Because I saw that there was like placental collection and things like that. I was wondering if you were involved in that.
Yeah, so we have UCSD has a Center for Perinatal Discovery. Thank you. The CPD, we've been doing, before I even joined UCSD, they've been doing collection for over 10 years for placentas. So the focus for the CPD is really placental manifestations during pregnancy and how that impacts health of mom and baby. So we're really focused on preeclampsia, poor fetal growth, so why some babies end up small. And so we've been, collecting placentas for over 10 years, have a bank of placental tissue that is used for research, and it's kind of a niche area that I think is underappreciated, but is gaining, some traction in the perinatal space.
Yeah, because I think I heard somewhere that the placenta is considered an organ now.
It is, yeah, and it's interesting because so we call it like the only temporary organ, right? It only develops during pregnancy. Once pregnancy's over, the organ's gone. And most of the models, my understanding, limited, that a lot of the placental research is based on is actually cancer, like tumor growth, because it actually is like an infiltrative tissue that develops during pregnancy and is kind of akin to the way a cancer develops and infiltrates tissue. So there aren't great models for placenta because it's kind of lives in this strange in-between area where it is a temporary thing but functions as an organ. It filters nutrients and waste. It's an interesting organ.
So earlier this year, you presented at UCSD's first annual Women's Health Symposium, where you spoke about the MOHD Consortium and the Mom Health Study. Could you tell us more about your work?
Yeah, so the MOHD Consortium is an NIH consortium that's really focused on, it stands for Multi-Omics of Health and Disease. And so there are a bunch of different centers across the country. There are 6 sites that are looking at all these different disease states and how multi-omics can influence those different disease states. And so understanding pregnancy is not a disease, but our disease state that we are focused on is preeclampsia and hypertension during pregnancy. So we call it the Mom Health Study. The idea is that we enroll pregnant patients during pregnancy. We follow them ideally throughout their first year postpartum to see how hypertension may develop either during pregnancy or right after. Most maternal deaths that are associated with pregnancy are due to hypertension or cardiovascular disease, and so it's a really big issue for pregnant patients. And so we're trying to say, can we predict who's going to develop these really severe complications, and hopefully find a way to intervene earlier so those complications don't develop.
Right, and I believe it's 2/3 of the deaths are considered preventable.
Yeah, so the idea is that if you were able to intervene earlier and identify somebody who's going to have a really severe complication, maybe we could prevent those deaths from happening. We could intervene earlier before it gets to the point where we can no longer help things, or help people understand when they should go see their doctor instead of staying home and maybe thinking like, oh, this is a big deal. A lot of times women's health concerns, sadly, are dismissed. So, women will call their doctor and say, I'm really concerned that this is happening. They'll be saying, oh, that's just you just had a baby, that's normal, don't worry about it. And then they let it go. And then they end up in the emergency department with a really severe complication that, either is too severe to intervene on. And that's when those deaths occur. So we really want to try to catch those before they get to that point and prevent some of these deaths that are happening.
Do you have any preliminary results from that, or?
We just started, so we're a year in. So this is it's a 5-year study. The first year, because it is a consortium, was all planning, which is wonderful. You spend a year planning how you're going to do your research with everybody else. It's like too long. And then we just started recruiting last year. So we're almost a year in. We'll be recruiting for the next 3 years. And we'll start doing data analysis at that point. So no results to share quite yet, but we really appreciate the enthusiasm of our participants. This is actually a partnership with Vanderbilt University, and so they're recruiting patients for the same study, and we are bringing all of our data together, which is kind of nice to have 2 different populations to look at, very different areas of the country, very different backgrounds. So hopefully we'll get a nice, robust patient population to kind of answer some of these questions.
Yeah, that's amazing. We definitely need more research.
I agree.
So even though your work lives in different corners of medicine, one on clinical research, one on emergency medicine and administration, I guess, do your careers ever intersect in the conversations you have at home, or do you bounce ideas off of each other? Do you tend to keep your work separate?
I think that we do bounce ideas off of each other. I mean, yeah, emergency medicine is very different from, the perinatal space, but I think in kind of a bigger sense we do talk about work. So I know, sometimes he'll come to me and say, hey, we're talking about this research in the emergency department. What do you think of the study design? What do you think the limitations are? Is there something I'm missing here? So it's kind of nice to talk about like the research space. And then because I'm not a clinician, and I live in the research space, sometimes I'll be doing research and say like, hey, as a clinician, would you care about this? How should this be framed to make a clinician care? And sometimes I'll say like, that's kind of silly. No clinician's going to care about that. Or sometimes they'll say like, oh yeah, I would say that the messaging might need to be phrased differently to make a clinician understand how this could help them. So I think kind of in a broader sense we do. And also the bureaucracy of UCSD, but that's a separate.
Yeah. Yeah, I think so. The day-to-day we probably don't talk as much about. I'm probably more reserved about the clinical aspects of care. It's maybe I kind of close things off. I'm not the best at talking about some of my feelings or challenges, I think, on some cases that come in. So I think you sometimes want to know about that and hear about that, but I just don't really talk about it.
But it's mostly because as somebody who doesn't see patients, I don't know what the issues are, right? Like I spend some of my time teaching OBGYN residents, and what I keep saying to them is they're like, I don't want to do research, I don't know. And I'm like, but you're where the ideas are. You're seeing the patients, you know what their questions are, you know what you can't answer for somebody when they come in and say like, hey, this is going on, do I have to be worried? If your answer is, I don't know, then that's an area for research. And so I think that's why I'm interested in what's going on clinically, because that helps research directions and like what we should be looking at.
True. I mean, we do talk about where sometimes I'll have ideas as far as from a research standpoint, and I'll kind of throw it at her because she's obviously the expert and from the research side, and that is not it's not my forte. Like I understand it from my training. I understand it, I think, more from her explaining things to me. But I like to have some discussions about, like, is this feasible from a study design or statistical modeling? Can this be done, or does it make sense? And so that's really helpful to have these kind of discussions, or things will come up and be like, we had this discussion at journal club, in conference. It's like, this didn't make any sense to me. What do you think about this? And I'll throw it at her and see what she has to say about it, and I think that's beneficial. But at the same time, we do have some overlap. We're a little bit different because she's mostly on the adult side in OB-GYN, and I'm mostly on the ped side. That being said, since we're both at UCSD, there is overlap, and I think there have been research opportunities that come up. Like, we'll have a discussion, and she'll be like, who would you talk to for XYZ? And I'd be like, hey, I'd go to this person and have a discussion with them. Or I'd ask her, like, I've met with some of her faculty who are on the UCSD School of Medicine side to get, like, career advice, mentoring, opportunities. It's like, I think for me, it's, and we try and talk about this, is like, don't pigeonhole yourself into limiting your mentorship and your contacts. And so it presents opportunities for the both of us to talk about things. And it's just nice to hear different perspectives, and also to see how the adult hospital may do something, or how OB-GYN does something. Or, like, I've met some of her faculty, and there's discussions about how they run their finances for their division. And it's fascinating to see some of the differences or lack of understanding about how that works. But also our funding is, like, very different for what we have to do. Like, I think her in the research world, it's very much, you have to get grants. It's not even like publish or die, really, right? It's like, get grants or die. And obviously on my side it's a little bit different. So we have different goals, but we talk about things, I think, a decent amount. And, like, we've had some overlap where, honestly, like, through the MBA, we've met some of her colleagues and had discussions about kind of entrepreneurial opportunities, which, again, is a little bit outside of my wheelhouse, but I think it's fun to have these discussions and talk with people who are like doing some cutting edge stuff on her side of the world, and then adding in some of my perspective from having done the MBA, but also I think being I'm more of a pragmatist and have an idea of like how can we make something that's beneficial for more people. So yeah, just not as much as the direct. I rarely will talk with her about like there was a rough patient today. It's rare, but she'll hear me on the phone talking about clinical disasters or professionalism issues that come up, because unfortunately or fortunately those fall under my purview and my roles. So she'll hear it and then she'll be like, wow, that was wild.
Well, just from our conversation, I feel that this is very exciting to have so many different experiences and bringing them together, diverse perspectives and the breadth of experiences and opportunities you guys are exposed to.
Yeah.
It's a lot of fun, actually. Yeah, I mean, there's always so much going on, and it's always so different. And so it does make things interesting. I can't imagine living with somebody who does something exactly like I do. I think that would get very overwhelming. And a little bit boring to be talking about the same thing all the time.
Yeah.
It's nice to have somebody who at least tangentially knows what you're talking about, but maybe is not so into it that they're going to be, talking about the exact same thing all the time.
Yeah, and yes, I mean, you like to. The other thing is because she's on the research side on a PhD, and I'm as an MD, obviously. It is funny to get outside of the medicine part of things and have her perspective on doctors and my perspective on research, and we'll have some fun conversations at times where she will go off on your doctor buddies are the worst, and it's like, why? Please tell me more. Let's talk about this. And it's just interesting because I think the type of people that, whether you are running a Fortune 500 company or you're a PhD level researcher, scientist, whatever, academician, or a physician, is like you're talking about like really high functioning people who have really lofty kind of goals, I think. And it is interesting to see some of the interpersonal dynamics that occur or the challenges that occur with some of these people. And I like to get her perspective and her complaints, because sometimes it's like, you're right. You're right. That's pretty spot on. So.
Hey, so a little break from our conversation. Oceanside Perspective is a 501c nonprofit dedicated to human skills education. So we would appreciate any support from you, whether it's liking this video, subscribing to this channel, or subscribing to our newsletter below in the description box. Thank you, and let's get back to our chat. So you mentioned that you teach residents, and you both are professors. How do you each think about teaching? Do you have similar teaching styles? Is that something you bounce off of each other too?
We don't talk about it so much, actually. I feel like individual teaching, probably for you clinically, but me it's more mentorship. So I do a lot of one-on-one mentorship. I don't know. We don't really talk about teaching that much. I love the one-on-one mentorship. I don't love lecturing so much, which I do once a month maybe. It's not a common thing, but I really like the interaction with people, and I feel like when I'm lecturing to a big room of people, it loses some of that, and so I don't love it. But you're a much better, I think, teacher, like, big group speaker and teacher than I am.
Yeah, I don't know. I mean, I haven't seen you, I think, give a lecture, so I don't know. I mean, for me, I do teaching at the School of Medicine a couple times a year, whether that's with medical students, with residents, and we have like a breadth of residents, right? Like you're with OB-GYN. Mm-hmm. We have family medicine, emergency medicine, pediatrics. We have PA students. We have nurse practitioners. So there's kind of a breadth of people that you kind of have to teach. And I think for me, we don't really talk about it as much, like style, But for me, it's more of what is it trying to get on the individual level? Because a lot of it for us is you have the regular classroom teaching, which is very different than the clinical focused teaching. And so for me on the clinical side, I really try and sort through, like, at an individual basis, like, what is it that you want to get out of a certain session? What are your goals? What is your goals for the session? But also, like, what are your goals for your career life, which is really hard to do on a quick basis, which we don't always have the same people over and over again. And it's kind of tough to get to know somebody. But that being said, like, I try and do that at the beginning of any kind of shift, is who they are, where they're coming from, what they want to do long term, what they want to do kind of right now, short term, and then trying to tailor some of those educational opportunities to the individual then. I think there are certain things, like, you're in the emergency department, so you're going to have to learn this now. But there are certain things that, like, I don't think are beneficial for certain individuals, and the individual, if they don't think it's that beneficial for them, then it's not necessarily the most helpful to kind of push that on them. I like to be, again, more of a pragmatist, but also try and let people know, I think with my educational style, is not being so dogmatic, having the trainees kind of question things, let them kind of come to their own conclusions, and we may not agree. That being said, there are times where I will let them do something that I know won't be the most beneficial if it's not harmful. So I think for me, it's like, as long as somebody's not doing something harmful, it's not, I don't care as much. But that being said, there's harm is a very nebulous term, because you have that, like, physical harm of, like, are you doing a test or some kind of invasive procedure that is harmful? Well, what about financial harm? What about social harm? There's a lot of those other types of things that I kind of think through, that try to have discussions with trainees. And then, you know, for me, it's very much like I like to provide evidence for what we're doing. Unfortunately, you know, I think people think that there's evidence for every single thing that we do, and that is not the case in medicine. There's a lot of vagary. Yeah. And so it very much is kind of like there are multiple ways to do something. And so present those ways, present that logic, and if there is evidence, show, like, hey, there's actually some research for this. This is why I would do this instead of this. And so that's always my goal. And I think it comes across well most times, but I think it's sometimes hard when I'm in my clinical role. I'm still administrative, and everything comes to me when I'm on shift. And so sometimes there's, like, a frustration that I also have to hold back for the trainees, where I'm just like, all right, don't get upset. Don't show the frustrations. And, you know, it's tough. But at the same time, like, I don't know if it's a bad thing to be human in that way, to show them, because then they get a clear sense of how medicine actually is. I think for people going into medicine, there is a idealistic way of what of what medicine looks like, and it's not that. And that's not to be negative. It's just, I think you have to have a realization of what it is, especially for people. I mean, I think do you have anybody in your family that is in medicine? So that's right. Like, if you've never had anybody who's in medicine, you don't have that that, like, built-in familial mentorship to have a discussion. Like, yes, my mom was a nurse, but, like, she doesn't know what it is to get to being a doctor, all the other steps. And so if you never had anybody talk you through the difficulties, you don't know, and then you kind of get blindsided when you're there. And to an extent, there was a lot that kind of opened up, like, wow, this is what medicine is actually like. Again, not in a negative way, but more in a transparent way of understanding what that looks like.
Yeah, I guess there's just some things that you need to experience for yourself.
You do, or have people that you can bounce questions off of, that you can try and understand. You're right. I think experientially, at least for me, we all have different learning styles. Experientially, that's how I work. But you're right. You won't know how it is until you're actually in it. So I think maybe it is. Like, you get to have these conversations. It's helpful to kind of hear all the different perspectives from people, their journeys, their frustrations, their goals, and also their views on medicine.
So I want to pick your brain a little bit about where each of you see AI impacting your respective fields.
Do you want to have a go there, or do you want me to have a go?
I mean, AI is becoming huge in research, for better or for worse. I think that there is definitely a place for it. So a lot of, from my experience anyway, a lot of it's moving towards precision medicine. So whether we can use AI predictive models to better predict the best course of treatment for somebody, or better predict what a likely outcome is for somebody. And I think that that's great, but I think that it also brings up, for someone like me who works in an area of disparities research, whether that can bring up disparities for people. So that means people who have potentially more access to medicine are going to have better models predicted for them than somebody who maybe has less touch points with a medical system. And so I think that that's kind of an ethical question that always comes up for me. Not to mention that I think a lot of people, because AI is so easy, you just, tell the computer what you want it to do, that it's doing things, but people don't actually understand what it's doing. And so from a research side, I've noticed, the AI just takes whatever it can find and tries to make something fit. And so you might have something that AI is saying, this is really important for this outcome. And you're like, that has nothing to do with this outcome, like biologically speaking, but it just tries to find patterns. And so I think that there's the possibility of using it incorrectly, but if it's used correctly, I think it has a lot of promise. The other thing, and this probably goes more to your side, but sometimes I think it would be great. People need a touch point with medicine a lot of times, but a doctor or a nurse isn't always available. And I could see that being really helpful for somebody who maybe just needs to say, like, hey, these are the symptoms I'm having. Should I be concerned? Who should I call? And to actually have something back and forth that's saying, have you checked your blood pressure? Have you done X, Y, Z that maybe could help people have better access, but that's probably not without its limitations or complications.
Yeah, I think you're right. The way I look at AI there's a lot of different categories, right? There's, I think, on the there's drug development side in medicine, which I think there's a certain boon to that, and that'll be very beneficial. That's a little bit outside of my expertise. I think you have, like she said, you have kind of machine learning, looking at how do you improve clinical pathways, how do you kind of have that more kind of precision medicine. And I think that stuff is fascinating. And that's coming. I think integrating that within electronic health records are really beneficial. And then there's also the kind of wellness side of what AI can do. I think there's a lot of the menial administrative tasks that we don't think about that probably take up more time than we consider, and are things that, is it really necessary for a PhD level or MD level to be spending this much time putting together emails, writing letters of recommendation, writing notes? There are a lot of things that it can be beneficial for. And so one of the actual aspects that at the Children's Hospital at Rady, and it's happening in other institutions as well, is kind of the ambient scribes. So AI to basically capture the conversations and create a note that you can then edit and use. And to be honest, within our space, we have a trial going, and I was able to use it, and it is impressive. And on, I think, two fronts. You have the physician wellness part of it, where I can just put it there. People are saying, hey, I'm getting done all my notes before I get to go home. So there's that time that you see like, oh, I don't have to spend an hour or 2 hours at home doing notes, which is essentially uncompensated time. And that's huge for wellness, which is a significant issue in medicine right now. And then the other part is the patient interactions with it. So like to be able to put down the device, to be able to just have a conversation and not being sitting there like typing and giving your full attention and focus to somebody, I think is meaningful. And you see like the interactions with the patients, I think, are just better. And you actually, I think, get to focus a little bit more on what's going on. So that is something that is coming and is being implemented. It's just, there are some limitations, I think, with a lot of these AI applications such as that it is expensive. And at the same time, there are some other challenges, like how do you integrate trainees? Do they get this software? We have, hundreds of trainees. It's on a per person cost. What do you do for that when they're only with you for a certain amount of time, or if they're from another institution? Who pays for this stuff? I think that the operations side of things, we've actually had some discussions with external companies to look at how do we integrate AI into our electronic health records and the actual operations of the hospital to determine what's the best place for a patient to go to, talking about space. And so there are these great opportunities for that. Again, some of the issues that arise with AI is the most valuable. I was actually talking about this on an interview for a faculty member, that one of the issues that comes up is the most valuable part of some of that information is the data for a hospital or an institution. So a lot of these AI companies are not necessarily full formed. It's not, ChatGPT who's coming in and has like billions and billions of dollars. You have a lot of these smaller companies. They're not going to pay you for that data. And so basically, like, you're giving away data for free to allow them to grow, or for a very small amount. And is that something, again, it comes on to the business side, is that something as the institution you're willing to do? And because there are so many companies, how do you kind of vet what is the best way to go there? So it is promising. It will, I think, help with streamlining care. It will help with wellness. Though, there are some of the drawbacks and concerns that people have raised where, you talk about that ambient listening for notes is like, okay, well, let's say I'm spending less time having to write notes now. Is there going to be the expectation that time being saved is now going to be you're working harder doing something else? And I think that is some concern, that we don't want to just be working harder because we're saving time somewhere. Like, we're already all working very hard.
Yeah, I was just listening to a podcast this morning where he was talking about the future of gene editing for sleep. So there are genes isolated for people who can sleep like 4 hours and they're fine. This is perfectly okay for them. And it's like, what are you going to do for those other 4 hours now that you have that in your life?
Exactly.
Be more productive,
Right.
Do more work, make more money.
Yeah. Yeah, I mean, that's you're right though. I mean, I think I saw that article, but yeah, it was what are you going to do with that? Like, if you don't need to sleep, I get it. And if there are things that you want to do, that's fantastic. Like, is that really what you want though? Again, it's on an individualized basis, right? Is it work? Is it, maybe you have a hobby that you want to do? Maybe there's, maybe you want to make sure that from a fitness standpoint, like, you're doing well there. So I don't know. I think maybe it provides the opportunity and it just has to have some considerations. I don't know.
So AI is definitely a double-edged sword. Can be used very incorrectly or very, very useful. And I'll say that I'm recently hired as a cardiology scribe. So
Ooh.
I do know that scribe jobs are getting eliminated slowly but surely. But hopefully we can work together with AI in that sense so that there are still entry-level jobs for pre-meds like me.
No, it's good. That's pretty cool. Yeah, we had when I was a resident, actually in our cardiology clinic for peds, they had scribes that were pre-med students. So it was really cool. I think it was nice to have that. Even as like when I was in fellowship, they had that, and we never had those, but it certainly. I mean, you can attest to this. Given the opportunity to get that clinical experience and to see the real day-to-day has to be something that is valuable. So
Yeah, absolutely. So in one sentence, what do you consider your purpose or your why to be today?
Oh, gosh.
Big question,
I
but it
know.
is called Purpose Why Medicine, so I have to ask it.
I think I would just say to improve the health and life experience of our patients or people in general. I think I'm all about improvement. So how can we make lives better for people? Yeah.
yeah, mine has changed. I think I had that idea before, like. I don't want to say it's naive. Maybe it is. But I think it's moved into almost this idea, my purpose is I want to be able to give the people that I work with, the physicians, the nurses, the techs, like I said before, our staff, I want to make sure that they're well, that they're thriving, because if they're not, they can't take care of patients. And so for me, it's kind of moving into that space of how do we make everybody as well or thrive as best as possible so they can provide the best care for everybody else.
So if you could do an elevator pitch for each of your careers, for those pre-health professionals who are listening, what would you say?
I'm not sure if this is an elevator pitch per se, but I would hope that people would consider that being a doctor or clinician in the traditional sense is not the only way to be involved in medicine. I think that too often people think that that's the only path, and that's why there's such a big split between research and medicine, is because there aren't a lot of people in the middle that are actually doing clinical medicine well. It's usually clinicians that have sort of drifted in that direction. And that's not to say that there's anything wrong with a clinician doing research, but there is something to be said for actual training in research. And I hope that people would consider that for me, I knew that I didn't want to see patients. And so if you're the kind of person that's like, I love medicine, I love the science of it, maybe I don't want to see patients, maybe consider whether research is a way that you could go. No offense to the clinicians, but we impact more people. I mean, our reach is wider. We get to, further the future of medicine and treatment of patients. So I would say that we have a big reach and can probably have a bigger impact on more people.
Oh, that's certainly one point of view. I like that. I think I'll actually stay in the pediatric emergency medicine realm of things, like be a little bit more specific with it, is going into medicine, or being a doctor. Yes, I agree. If you want to be involved in patient care, it's one way to do it. That being said, the way things are now, you can be a nurse practitioner. You can become a physician assistant. You can be a CRNA. There are a lot of things that you can do that don't involve being a doctor, an MD per se. That being said, I think going that route, the difference between, I think, some other venues is you are able to practice at probably the highest level of medical care. You are able to use logic, to understand research, to better provide, I think, some of that clinical care. Though I would say it's a long pathway. Pediatric emergency medicine, on the other hand, what I would say for that is it is a great lifestyle choice. It's one that, yes, it takes time to get there. And that being said, as a generalist, you're a jack of all trades. I think there's something that like keeps you interested, and if you get to do everything, have a little, if that's your style and you want to dabble in a lot of things, it's fantastic. You get to do procedures, you get to practice clinical medicine, and you're an educator. You know, you're gonna have to do some research if you're in an academic setting, and at the same time, you get the benefit of working a non-traditional schedule. And so that means typically less actual days than other people. And I think for people with families, people with kids, or without, you get to have a different lifestyle. The only thing is you're going to have to do some weekends, you're going to have to do some nights, you're going to have to do some holidays, but you get the benefit of, you know, you're working, you know, you're not working Monday through Friday. You're not in an 8 to 5. And if you like that kind of non-traditional atmosphere, it's fantastic. And if you like people say like the rush of emergency medicine, that's there. And I think more than the rush is the relationships you have to build very fast. There are very few specialties where you have to meet somebody, you have to gain their trust within 5 minutes, you have to make sure that you're going to provide the information that they need, and they're going to take that information and they're going to be able to kind of move on through the rest of their day. And I think there's something really unique and special about that you're not having that continuity of care. If you're having continuity of care in the emergency department, that's probably a bad thing. But it's really fun to kind of build that relationship really quickly.
So thinking back on your careers, you going through residency and medical school, and as well as getting your PhD around the same time, would you do anything differently?
I don't think so, honestly. I mean, I think meeting him right before starting my PhD and probably you starting medical school kind of threw us for a loop a little bit. I mean, yeah, knowing now, maybe we would have figured out a way to do that in the same place. But I don't think I would have done anything differently, per se. Yeah, I don't know. It's not really a great answer, but no.
Yeah. Maybe this is like super old school. There's that like Frank Sinatra classic, My Way. Like, I am very happy for the most part of the way that I went through to get to where I did. And maybe this is, revisionist, is it did come with a lot of challenges. Being long distance from her was tough. Being long distance from my family, my mom has some medical issues, was tough. Being in a different country, even though, yes, they speak English, even though it's weird English, it was challenging. I think the financial burden that kind of comes with it is when you talk about, hey, you're going to come out with $300,000 plus of debt. Are you prepared for that? I wasn't aware of what that was going to look like. I wasn't aware of necessarily how long all the different training was going to be, how long's residency, how long is fellowship. Oh man, it's a long time. That being said, I don't really regret any of it. I think there are things that I could have done better. I think my lackadaisical nature in undergrad kind of followed me through a little bit of medical school, and those are things that I probably could have put more focus on. But that being said, like, maybe I didn't do that because it took some time for me to really get invested and really interested, and maybe I did it in my own time. And I think everybody has their own individual pathway or educational styles. Some people are really good at sitting down and just focusing and studying and going through questions. And for me, that at that time, it just wasn't. It wasn't it. And again, maybe I could have been better. Maybe I could have put myself around people that were gonna push me to do that. But I don't really have any regrets on how that worked out. I think there were, in fellowship, I think there were some differences of opinions on certain things that were not like outside of our personal dynamic, but just like interactions, like difficult interactions. And I think that's one of the things in medicine. You think you go into medicine that it's like an apolitical venue, that it's this collegial atmosphere where everybody's on the same team and everybody has the same goal, and it's not quite like that. And so I think learning to understand the politics, learning how to have difficult conversations, to maybe not be as aggressive for certain things, I think could have been beneficial. But that being said, like, I've learned now, or at least I think I'm better now because of those things, and maybe it's something that had to occur in order to get where I'm at.
What do you think? Also, sorry, I'm going back to the original question. Gone, detoured. But I don't know. Like, there is the career aspect, and then there's the personal aspect, and it's a balance. So maybe there are things I wish I'd done differently career-wise. For a PhD, moving around a lot is not great because a lot of times you establish yourself in a lab or in a research program, and hopefully you're doing that during your PhD, and then you're moving into a postdoc, and then that's kind of filtering you into a faculty position. But because of his training, I moved around a lot with him, and so I didn't really have that kind of laid out pattern. But if I'd followed that pattern and stayed in San Diego the whole time, because I did my PhD here, I don't know what sacrifice that would have been on the personal side. So it's hard to say I would have done things differently because I don't know what the impact would have been on the flip side of things.
But do you think, this gets very like nitty gritty, but do you think though, if you would have stayed here, right, like you're an assistant professor right now, based on, at least this is my personal opinion, based on your CV, based on your research, like there's no way in my mind that you're not an associate professor. There's no way that you wouldn't have, I think, furthered in your career. And I mean, don't you think?
Yeah, that's kind of my point, is like I think that I may be in a different position. I think honestly all the moving kind of held my career back a little bit because it was like postponed. So yes, I'm a little bit behind where I probably should be. And I think that's a result of that. But that being said, like, maybe I would, hopefully I'm up for promotion now. Hopefully that will happen. But maybe I would already be there, but maybe things would be different personally. I can't say that that's any better. So I think you do make sacrifices when it comes to trying to balance two professional careers and a personal life. Yeah. You definitely do make those sacrifices. And
we did. We had conversations at the time where it was very much like, all right, where am I going to go for residency or where am I going to go for fellowship? Residency was a little bit more limited, but then like for fellowship, it was very much like, okay, where's going to be, like honestly, I think we kind of traded off on this. I was like, what's the most beneficial for you? Where do you want to be? And so we kind of tailored it on like what was going to be the best place for her to go, and that's why we ended up in DC. And that being said, like I was not opposed to DC. I love DC, but that was why we ended up there. And then afterward, it's again that kind of, it's a discussion. I think as long as there's that discussion and some of that shared decision making, it works out. And not everybody's going to get what they want every time, but again, it was like after fellowship, it was like, where do you want to be? Like, here are the options. I mean, initially it was like, hey, let's go back to California, or let's stay in DC. Her family's in Boston. And I was like, do you want to go to Boston? She's like, no. And I was like,
cold.
Okay,
much too cold.
Sounds good. Or it was like, hey, let's go to California. Okay, that sounds great. But then she was like, hold up, I don't want to go to Northern California. And I was like, why? You're basically limiting my number of job opportunities by half by doing that. And it was just like, that's just what I don't want that. Like, if we're going to do that, I'd rather stay in DC. And we had those discussions, and I think it was like good to hash that out and make sure that we're on the same page so we're not misrepresenting ourselves when we're on like looking for jobs. And I think it was just easier. So, yeah.
Well, thank you so much to you both. I consider you guys to be like an ultimate power couple. So thank you both for taking the time to share your journeys and experiences with me and our audience today. I definitely learned a lot about your respective fields, and I'm sure our audience did as well. Thank you both again for the work that you do for your patients, their families, and your students as well, and I wish you the very best.
Thank you. Thank you for having us.
Thank you.